So the biggest goal here was when we think about neurocritical care and we think about pediatric patients, there's just a lot of variety in the kids that we take care of. And in the hospital, there can be a kid that comes in with seizures or status or another neuroinflammatory condition. And although we have clinical care pathways that we often use to guide that care, that's taking care of the vast majority in common patients, but each individual patient may respond differently to all these therapeutics, or they may need a different diagnostic path. And so how do we think about making sure that each patient is getting the right care at the right time in the most optimal way really requires a little bit of a rethinking of how we respond to each patient and think about them. We kind of broke this up into a couple different areas. So we have Dr. Benedetti is talking a lot about some acute onset, very refractory types of seizures in a syndrome called Fires and Norse. And these are kids that never had epilepsy or seizures before that come in and start seizing and they just don't stop seizing. Ultimately, there's a lot of different causes that are underlying that we don't really understand yet. And as we're starting to understand it, we know that many of these patients need new immune therapies, they need rapid diagnostics, including rapid genetic testing, and new quantitative ways of looking at their EEG in response to therapies so that we can better target the underlying causes. Right now, often what we do is we kind of throw steroids or plasmapheresis or IVIG at patients when we think of the neuroimmune process. But we really have to take a step back and start to use some of these new novel therapeutics that have been involved, including anakinra and tocilizumab, just as some examples. But we're really at the infancy of understanding this because we don't know all of the molecular diagnostics that will help us target and have better biomarkers to know what medicine is going to be best for those patients. Dr. Harrar is talking about how do we treat status epilepticus with some of the newer anti-seizure medicines. There's been a trial looking at ganaxolone, which is a new therapy that just finished. Unfortunately, it didn't meet both of its primary endpoints, but there were some exciting signals in there that might say that there's ways that this drug could be used, and I know the company that's developing that is looking for different options, but I think there's some exciting signals there for a drug like that that's a neurosteroid. And then we're starting to use other drugs that we've used before. Ketamine is a good example that is being used much more to treat status epilepticus in children, but the evidence for that and when it's best to be applied are still being better understood. She's published a recent paper looking at this in kids with cardiac disease that really shows that it can be a really great therapy, and there's a new study that's underway soon to look at early ketamine in children and adults for status. One of the most important things that we deal with in pediatrics in particular, where we see as an example, some drug or some therapy that's been developed in adults and has been approved for something related to child neurology, either for status epilepticus, for Norse, for a genetic epilepsy, but it hasn't really been tested in children yet. But we often have access to those drugs, and we have to figure out how to use them. Are they appropriate to use? So we have to deal with this question all the time. There are large groups that are trying to develop consortia to pull together data in pediatrics. One of them is a group that I work with called PedQuest that is built to try to create an infrastructure to collect patients from all across the country that are pediatric centers, because we run into two main problems. We have diseases that are common, but we need a lot of those patients to better understand how to target therapies. And then we have diseases that are rare, like Fires and Norse, where each individual institution might have a handful of patients a year, and that's just not enough to study. And so we're trying to pull together large samples of kids using these types of infrastructures to better understand responses to therapy. So we're not just doing correlations or associations or individual cases to drive our care.